After the complex crosstalk made simplified by Dr. Madhumita, I'll be talking HCC in Budd-Chiari. Simple topic, a little complex to diagnose. Budd-Chiari, we know it's seen in around 5 per 10,000 per patients, median age around 46 years, prevalence of 1.4 to 7.7 per million. 70% of patients may have underlying risk factors, but 15 to 30% will not have any kind of underlying risk factors. The risk factors vary across the geography. India, the studies from Bombay have been quoting that JAK2 mutation is quite common in these patients. It's a triad of abdominal pain, hepatomegaly, and ascites, and up to 20% may be asymptomatically diagnosed with Budd-Chiari. What we are discussing here today is HCC in Budd-Chiari syndrome. I'll discuss 3 studies, which are the retrospective studies basically. This is Swedish registry-based data. They compared the incidence of HCC in Budd-Chiari with cirrhosis and those without cirrhosis and control subjects. These control subjects were age and sex matched population, general population. This database said that at 5 years, the incidence in cirrhosis population is around 3.11% and remained same at 5 and 10 years. While in cumulatively in all Budd-Chiari syndrome, all patients, it's around 0.5% at 10 years, which increases up to 2.5% at 20 years. In cirrhosis, it's exponentially high, it's around 8% at 20 years. In control subjects, much lower, less than 0.5% at 5 to 10 years. In fact, at 20 years, even it's less than 0.5%. So they quoted that there is minimal risk of hepatocellular carcinoma in non-cirrhotic Budd-Chiari syndrome, and it's a 3-decade population-based study from Sweden. This is a China-based study, a retrospective study of 113 patients. These patients have hepatic vein obstruction of the IVC in around 50 patients. Again, this is a common risk factor for HCC in these patients. The median age at the diagnosis of Budd-Chiari was 49 years, more common in males, symptom duration of 55, less than 1 year in 55 patients, and 58 had similar proportion in more than 1 year. Interestingly, what they noted was the risk of HCC is higher in patients who are males. These alpha-fetoprotein in these patients is very not characteristic, cannot be defined. It's quite variable, 3.8 to 20,000, very variable. So you cannot depend on alpha-fetoprotein. That's what it's difficult to diagnose HCC in Budd-Chiari. The incidence around 10.6%. The mean age at the diagnosis of HCC was 54 years. And it all occurs in the right side. The left caudate lobe is spared. It never did. Caudate lobe doesn't have any nodules. It never develops any HCC. It's always on the right side because of the vascular drainage. Most of the patients had single nodule, IVC block with a stricture of the hepatic venous outflow was led to HCC. Tumor size was 7 centimeters. Large tumors, right-sided Budd-Chiari syndrome, probably HCC. Treatment. These patients, what we routinely use for our treatment is the same thing for HCC in here as well. But what the important message is, we have to treat for Budd-Chiari as well, either concomitantly or prior to treating HCC. And these patients, when present to us, they have advanced disease and they usually end up receiving only locoregional therapy. As seen here, around 6 patients received locoregional therapy, 2 underwent resection, again 4 were in conservative management. So usually it is palliative management, but concomitant treatment of Budd-Chiari should be noted for these patients. This is the 3rd study from India, from AIIMS Delhi and KM Mumbai. Largest study till date which I could find. From AIIMS, this is the AIIMS cohort, 904 patients with Budd-Chiari syndrome. They compared patients with Budd-Chiari syndrome without HCC and with HCC. Contrary to the previous study where they showed that the incidence of HCC is more in males, here they didn't find anything like that. In the AIIMS cohort, the incidence was almost similar in men in both the groups. IVC obstruction, almost 70% had IVC obstruction with or without hepatic vein obstruction in the HCC group. So IVC obstruction is a risk factor for HCC. This is because of the impaired drainage. There is persistent hypoxia which leads to regeneration mechanisms leading to HCC. 100% of patients had cirrhosis in the HCC group. So these are all the risk factors. And long segment, presence of long segment tumors, again a risk factor for HCC. They classified this as those diagnosed at presentation or those diagnosed on follow-up. There are certain differences. Patients who were diagnosed at index presentation were pretty sick, advanced disease, high alpha-fetoprotein, thousands. Those who were on follow-up had 500, probably they were on surveillance. Their tumor sizes were less. The number of lesions were although larger, but the number of size of the lesions was small. BCLC-B was, most of these patients were diagnosed on BCLC-B, while when they present to us, they present in either BCLC-C or advanced disease. The prevalence at diagnosis around 2%, incidence on follow-up 0.36 per 100 patient years. The treatment received again Most of the patients receive palliative care. 51% TACE, around 3%, one patient undergone a tear. TKI is in around 8.5%, and none of the patients in this cohort underwent transplant. But patients who received treatment, they had excellent survival at 3 years. 27% at 3 years survived if they received any form of treatment. And 75% had undergone some form of therapy for Budd-Chiari syndrome. That is, most often it was plasty of the hepatic veins or the IVC. In the Mumbai cohort, again, this is similar to the Western cohort, where they said it's most often the males which develop HCCs. And 8 of the patients were diagnosed at the index presentation. They are all in BCLC-C, advanced child score, probably receiving only conservative management. Only 2 patients could undergo transplant because of transplant center. This is all what we learned from the incidence of HCC in Budd-Chiari syndrome. What is the incidence of number of patients with Budd-Chiari syndrome which we get when the patient has HCC? This is our data, around 920 patients. The proportion of viral and NASH is almost similar. Only Budd-Chiari accounted for only 4 patients, that is 0.4%. These 3 were males, only 1 was female. All of them had cirrhosis. They were diagnosed average around 3 years back, saying Budd-Chiari syndrome. This was the index presentation to us. Average size was 4 centimeters. 2 underwent original therapy, followed by 1 undergoing liver transplant, and 2 patients only received tyrosine kinase inhibitors. Again, 50% will be eligible only for palliative care. The actual problem is not about diagnosis or management. It is not about management. It's about diagnosis of HCC in Budd-Chiari syndrome. The reason being, there are FNH-like lesions which occur in patients with Budd-Chiari syndrome. These are called as FNH-like regenerative nodules, which are seen in 36 to 44% of patients. It occurs because of the impaired venous drainage, portal flow deprivation, increased arterialization. And we biopsy them. You just have simple hepatocytes, no portal vein, only enlarged hepatic artery, which is seen over there. They almost always occur on the right side of the right lobe of the liver, and 30 to 60% may have scar. If the size is bigger, around 60%. If the size is smaller, around 15 to 20% will have central scar. They are usually numerous and range between 3 to 4 centimeters. And they also disappear when you treat the patient with either TIPS or recanalization. But they never go into malignant transformation. And we have to differentiate between FNH like regenerative nodules and adenomas. So basically, adenomas, they are usually in females who have estrogen exposure. The fat suppressed image to look for fat may be present in the adenoma but not in FNH. There is pseudocapsule in FNH like lesions but not seen in adenomas. There are vascular abnormalities always noted in FNH, but almost 50% may have vascular abnormalities in adenomas. The second thing we have to differentiate is FNH like lesions from FNH as well as HCC. FNH is a diagnosis of young male who comes with a single large nodule of 1 to 11 centimeters, usually solitary, and the patient doesn't have anything else. This is FNH. But in Budd-Chiari syndrome, the patient may have some background parenchymal disc changes of vascular abnormalities. The size is around 4 centimeters, multiple. May have ascites because of the disease, underlying disease per se, and may have dilated veins on the abdomen because of the disease per se. HCC, on the other hand, it's varied. The numbers can vary, the size can vary. The parenchyma is always cirrhotic, and ascites may be present if the patient has come at advanced stage. There may be dilated veins if there is IVC obstruction as well. But one important thing, LIRADS doesn't apply to Budd-Chiari syndrome. There are 3 or 4 conditions where LIRADS doesn't apply. One is liver mets, one is post-transplant, third is Budd-Chiari syndrome, and non-cirrhosis. These are 4 situations where LIRADS is not applicable for diagnosis of or classification of HCCs. And on MRI, this is one important thing. In an hepatobiliary phase, in HCC, there is homogeneous hypointensity, whereas in others, there is either it is isointense or there is just hyperintense, as in the central scar. Also, central scar, which is helpful in diagnosis of FNH-like lesions. Arterial phase, in FNH-like lesion, there is homogeneous hyperintensity, whereas in FNH, is a hyperintense mass with a hypointense central scar, which is almost always seen. In HCC, it is late arterial enhancement with washout with rim enhancement seen in these patients. So why do these patients develop nodules? This is because of the abnormal perfusion. There is outflow obstruction leading to sinusoidal dilatation, filtration of the interstitial fluid, hepatomegaly, pain, ascites, persistent hypoxic injury, especially greater in patients who have IVC obstruction, features of portal hypertension, parenchymal disease. There is a responsive hyperarterialization leading to increased blood supply causing nodules. These patient may also have portal vein thrombosis up to 10 to 20% of patients. And these are usually hypervascular and spread throughout the liver, most dominant on the right side, seen up to 30 to 60%, and usually multiple. So then the reason we have to diagnose HCC, this was an old study in 2008 from Dominic Vella's group, where they said they included 97 patients with Budd-Chiari syndrome with more than 1 year follow-up. 43 patients, almost 50% had nodules, 11 had HCC, and the cumulative incidence was 4% at 5 years. Male, factor V allele mutation, again IVC involvement, similar risk factors. How to approach is this is the reason, this was the study basis for all the guidelines to mention that AFP more than 15 is diagnostic for HCC in Budd-Chiari. Conversely, for other diseases, we take it as 10 as upper limit. Here, the nodule is there and the patient has AFP more than 15 nanograms. We have to biopsy the target lesion and diagnose HCC. If the AFP is less than 15, there are size more than 3 centimeters, homogeneous enhancement, again biopsy. If the size is less than 3 centimeters, but there is homogeneous enhancement, then just put him on surveillance imaging with alpha-fetoprotein every 3 to 6 months. They said that AFP more than 15 nanograms had a OROC of 0.85, sensitivity 72%, specificity 100%. If it is not there, then it's not there. PPV 100%, NPV 91%. Coming to what guidelines say, everything is routine like managing any other HCC and cirrhosis. The only thing is hepatic vein outflow should be restored before or along with the definitive therapy for HCC in a patient with Budd-Chiari syndrome. That is one important management aspect of HCC in Budd-Chiari. Rest of them is all similar to what HCC has. Presence of ascites does not always indicate cirrhosis, especially in these patients, and should not preclude any liver-directed therapy for these patients. Although the data on ablation is very, very minimal for these patients, there is no data on ablation at all for these patients with HCC in Budd-Chiari syndrome. To summarize, HCC in Budd-Chiari syndrome, more common in men than women, occurs in 4th to 5th decade. They are usually large-sized, right-sided. IVC involvement is common around 70% of the patients. Long segment thrombus is usually present. And cirrhosis is a significant risk factor. The number of patients without cirrhosis is hardly around 2 to 10% variable in the literature. Differentiating between HCC and regenerative nodules is critical. AFP more than 13, 15 and size more than 3 centimeters, probably issue may biopsy. They usually present at advanced stage. The only treatment left is usually palliative locoregional therapy with or without systemic therapy. If possible, liver transplant as and when possible. Thank you. I request you all to attend please AIG Live at September 2024. Thank you.